Hi, this is Dr. Viral Parekh. Welcome back to YouTube channel of Calcutta Academy of Radiology. We are back with the case of the week after a long hiatus. Here is another unusual case. This is a 62-year-old man who was admitted to the hospital with obstructive jaundice. An ultrasonography of abdomen was done, which revealed biliary obstruction at the lower end of the CBD. Subsequently, an ERCP was done very next day, which revealed a stricture at the CBD terminus. A biliary stenting was done in the same setting. Patient had undergone left nephrectomy for renal cell carcinoma about 10 years back. Subsequently, a triphasic CT scan was advised. Here is the complete set of images in arterial phase. What we can see here is there is a simple hepatic cyst. There is evidence of slight pneumobilia. Otherwise, liver and spleen under review appear unremarkable. Both adrenals are also unremarkable. There are multiple intensely enhancing nodular lesions in the pancreatic parenchyma, with the largest lesion here in head and uncinate process of the pancreas. The right kidney appears unremarkable except a small cyst here. Left kidney is not visualized. There is no evidence of ascites or retroperitoneal lymphadenopathy. Here are the key images. In this image, we can see an in situ biliary stent. Here is the lower end of the stent. Here is an image in arterial phase. We can see here multiple areas of nodular enhancement scattered in pancreatic parenchyma. Liver, spleen, and right kidney under review appear unremarkable. There is evidence of left nephrectomy. Here is yet another image in the arterial phase. What we can see here is there are multiple areas of nodular enhancement in pancreas with evidence of left nephrectomy. Liver and spleen and right kidney under review appear unremarkable. What we can see in this particular image is a moderately large, intensely enhancing lesion in the head of the pancreas, which was the culprit and was causing stenosis of lower end of CBD and was causing biliary obstruction. Now these are the images in the venous phase, which show that there is rapid washout of contrast from the pancreatic lesions. Here are two images in the delayed phase. What we can see that there is complete washout of contrast from pancreatic lesions and pancreas looks almost normal. So from all the images, we have come to a conclusion that above described pancreatic lesions are nothing but metastases from previously operated left renal cell carcinoma. Here is a paper which says that pancreatic metastases are an increasing clinical entity. They have mentioned that renal cell cancer represents the most common primary tumor by far, followed by colorectal carcinoma, melanoma, sarcoma, and lung cancer. It is not that there never used to be any pancreatic metastasis, but they are seen more now because of the improved imaging technique and better resolution of present day CT scanners. This publication further says that pancreatic metastases typically occur a long time after the removal of the primary tumor. This is particularly true for metastases from renal cell carcinoma, where an interval of over 10 years after nephrectomy is almost the rule. In this particular case also, the patient had undergone nephrectomy around 10 years back for left renal cell carcinoma. So to summarize and conclude, pancreatic metastases are uncommon and are only found in a minority, around 3 to 12% of patients with widespread metastatic disease at autopsy. They account for only 2 to 5% of all pancreatic malignancies. Although essentially any primary tumor may eventually deposit in the pancreas, the most common primaries encountered include renal cell carcinoma, which is one of the most common tumors that metastasize to the pancreas, followed by melanoma, breast cancer, lung cancer, gastric cancer, colorectal carcinoma, soft tissue sarcoma, prostatic cancer, Merkel cell carcinoma, hepatocellular carcinoma, papillary thyroid carcinoma, esophageal squamous cell carcinoma, testicular seminoma, and rhabdomyoma. So thanks a lot for viewing this video. See you soon.